again a panel discussion on group practice in nephrology. And to chair the session, thank you, may I call upon Dr. Amit Langote and Dr. Bharat Shah, sir.
Yeah, I think Dr. Bharat Shah is just come. May I request Dr. Prabir Rai Chaudhary also to be on the, for the simple reason that America has the best model, which we hope we will be one day able to emulate and have much more of group practice. So maybe if you are able to give some insights when at the end of the panel discussion. So please come and be a part of the.
And so I call upon Dr. Umesh Khanna sir as the moderator, and the panelists being Dr. Rajesh Kumar sir, Dr. Sonal Dalal, Dr. Mukesh Shetty again, and Dr. Shruti Tapiavalam.
So good afternoon. I think we had a good discussion on government, private, academics, and what we are missing in private practice. But I think a healthy mixture of all that could be in the form of a group practice in nephrology, which will probably bring in a lot of all these. We have around 30 minutes or a little less. I think I'll need to check timings otherwise. Most of these people who are sitting on the dais are, except Amit Langote, are part of or have been in group practice or are still in group practice. Some have been in and out of group practice. So I think that's a very good panel to discuss group practice in nephrology. And I think it's an idea whose time has already come, and that's for Indian nephrology scene. How many people in this audience will be happy to be in group practice if you were to start afresh? Oh. And how many people feel they are not cut out for it or will not want to experiment with it if you were to start afresh? Right. I'm surprised. You might be surprised at the end of it when we complete it that there are issues with group practice also. It's not a cakewalk. So, why group practice? Yes, as I said, it's an idea whose time has come. There are distinct advantages. You can create an impact. You can actually build an institution, which we are trying in Kidney Associates, that different people doing different things, and in the absence of an institution, you can build up an institute. We're hoping to create wealth. We have done a little bit, but not what Dr. Narendra Dedia would want us to be. And of course, there are a lot of subspecialty development which can be done in group practice. So I would not ask questions specifically to anybody. Whoever is wanting to answer can take it up. Now, there are many questions, so we'll have to be brief in it. What are the advantages of group practice? Anybody?
So I think, see, having practiced individually and later on entered group practice, exactly like Mukesh said, that initially start slow, wander around, and then settle down. Group practice has a lot of advantage in comparison to disadvantages, because you are a part of a team. The team itself gives strength. Everyone's strength is yours. Your weaknesses are hidden. Everyone's weaknesses are taken care of by each other. Everyone is an expert in something else, and you can take help from each other. No difficult case remains difficult because it is discussed. So that is very important. Your financial security is there because it's a team.
Okay. So
and it's a family. I think that gives a big, big boost.
Right. So since there are many other points and all of them can't be handled by each panelist, I've just listed some of them. Easy establishment from day one. You can do procedures, transplant. For example, the guys who joined me, from day one they were into a transplant program and doing all the procedures which otherwise in their own private practice would be difficult. Responsibility sharing, she said, free time, we all know. Financial security from day one. Individual management of your case, and yet there is an advantage of group's opinion. So we have that WhatsApp group in which you put up, this is the issue in this case, what is the opinion of the group. And of course, many of my 6 partners, they are pursuing different subspecialties in our own groups. And of course, you have academic development and negotiating power with hospitals and referring doctors, that we are a group, we can give you something better than an individual. And of course, medico-legal protection. Responsibility sharing is in emergencies, of routine duties, even finances. There is, everything is paid for by the company. of hospital attachments. We can cover up in the new, fresher can get attachments into many of the hospitals in which the group is, and of course the rounds, procedures, etc. All that can be shared. Somebody talked of free time. We are going to have work-life balance. I feel personally group practice is a perfect example of work-life balance. In fact, I'm able to do most of the activities only because I'm in a group practice. Of course, there is professional security and medical legal advantages and all. What are the disadvantages of group practice? Why is the whole of country not in group practice? Anybody from the group? What are the disadvantages of group practice? We'll talk about why others are not in group practice, but what are the known disadvantages of it if you have been in group practice?
So basically a successful group practice means you start with what is called as group of practice, where some people come together. Then there is true group practice. That means your purpose is served. And then corporatization of the group practice. That means you'll have CEO, CFO, all basically mechanics are like corporate hospital. Then only it works better. And it's a transition from forming a group up to corporatization. It takes nearly 5 years.
Yeah.
And many of them would not have patience to wait till it matures. So people will start finding that there are negative points in it and they'll follow.
So I think in this group, we have, for example, Shruti and Bharat are in corporate group practice, and there are many people who are in corporate group practice where 3 or 4 people are working together in department. I think Gujarat Kidney Foundation was like how we are. That means you are individual people, solos in different areas and combined in a few areas. Mukesh and Rajesh were in a setup which was slightly different, but these are different models of group practice. So there are disadvantages. For example, each one wants to do everything. You can't tell him you take only dialysis round. Somebody says you take only transplant round. He wants to do everything. There is a problem of trying to own a patient. This is not pertaining to the corporate setup, but in the solo group practice where we are at different areas like how I am or where Rajesh is, individual youngsters would also want that this patient should be with me and not with somebody else in the group, because owning the patient gives them that much of confidence, ego or whatever. There is fear of financial misdemeanors which sometimes can happen. Personal interest over the group, which is the main area where I think the issues come up. Financial insecurity in the sense, how will I be paid next year, 3 years later, 5 years later, unless we have systems as in place as the US has in terms of group practice. Star doctor phenomenon, they will say this, the chief or the senior, Bharat Shah is a star, but his newcomer who joins, he feels I will be treated as an assistant rather than an equal partner. So there is this, and of course there will always be a feeling in seniors' mind, juniors' mind about mismatch in the work and emoluments. And I think one of the main reasons why it fails is lack of leadership. You really require a very good leader, more of a statesman rather than a leader or a boss. So how to start group practice? I think I'll try and answer this because somebody has already said that there are different types of group practice. You can have a partnership firm, a private limited company, or a LLP, which you can initially start. And you could either have, like how Gujarat Kidney Foundation. And Sonal, could you tell us the model in which Gujarat Kidney Foundation worked, since you were part of a very, very famous group practice in Ahmedabad was Gujarat Kidney Foundation, which a lot of people wanted to emulate. It was one of the first successful kind of practice.
So we started up almost about 20 years back. It's basically a partnership firm, and 4 nephrologists, like some is more senior and the others are a little junior. Then accordingly, the percentage of remuneration is usually divided. But most important thing in the group practice is that along with the clinical work, what is you get is like if you are having a clinic, you have a pharmacy, you have a dialysis unit, you are going to different hospitals, then along with clinical work, you can divide this work also. Like somebody is looking at getting the patients, like they are seniors, so they are getting. Others are executing the work. One person is looking more at the pharmacy business. One is looking at the dialysis unit. So that division of work is also very important, because everybody is doing everything, then there is like lot of chaos and nobody is responsible for one particular thing. So that responsibility also is very well divided.
I think that is one of the disadvantages because everybody wants to do clinical work. Nobody wants to do research work or administrative work and pharmacy lookout. And unless you do all these things, you are not going to have a financially successful model. So you should decide on your model. Is it multiple nephrology clinics, which you hope that for example, in western suburbs of Mumbai, there are 7 kidney centers, all belonging to one particular group. And similarly, you start in multiple other areas of Mumbai and hope that someday Apollo, they have diabetic clinics of theirs and somebody will pick you up as, Apollo kidney clinics or something like that. So some people have that plan in mind. So that clinic model is an OPD, a lab and a pharmacy so that you have sustenance from other areas of income. You could add a small hemodialysis unit to it. So it has a full-fledged center with a daycare dialysis setup. You could have a nursing home, as I said in my initial nephrourology setup, which I had, in which we had dialysis unit, a urologist, an OT, and say 15-20 beds for hospitalization. That's a very typical classic small nephrourology clinic. And then you can have multiple chains of such clinics in the city of Mumbai or wherever you are. So 3 or 4 such clinics. So that's another nephrourology setup. And of course, people like, say, Vilas Nayak and many others who have a full-fledged hospital. You could have a kidney hospital where you could have, everything under one roof, or a chain of such centers. So these are the different models in which you can do group practice. Is there an ideal model or a structure to build upon? No. Customization is required. And you must deliberate on various models. As Sonal said, that you will have to keep meeting regularly and probably you must resolve to evolve. There is no fixed model on it. Yes, now our main question answers will be there. Why are people not joining group practice? Anybody? From Rajesh, Mukesh. Rajesh, you have been very quiet. Why are people not joining group practice?
So, most probably
in India.
Most probably people are not joining group practice is because they wanted to do, after 12 years of education, they wanted to have a leadership in their field. If they are working with some group leader or some seniors, they always be treated like assistant. And there is always a talk in front of them by the other colleagues or physician that no, Rajesh Kumar will not see, his assistant will come and see the patient. That feeling of this is preventing them to join a group practice. Second is whether they will make enough money out of that group practice or not. Senior will take away the major chunk and we will get hardly anything. So these are 1 or 2 things.
So is there anybody who can try and tell us what kind of formula will work in emoluments in terms of, say, 3 people joining, first year, second year, third year, fifth year? When should equality come into the financial sharing? Somebody getting more of, rest because he was senior, somebody getting, money, emoluments and work balance, which is fair and yet acceptable.
Sir, I think from what I've seen in Ottawa and other places where I've been, I think Dr. Chaudhary should also have his opinion.
That's why I want him on the panel to give his comment. You finish yours, then we can ask.
I think for the group practice, there are 2 things. You have to be equal in terms of respect, in terms of opportunity, in terms of representation of all the members to the general public. So everybody should feel that they have enough respect from everybody around and not felt as a subordinate to somebody else. At the same time, you have to have inequality in terms of positioning. There has to be a leader who would divide, assign, and everybody should agree to those roles and then comply with those chosen roles at that point of time. In terms of money, you should have a share or a sharing percentage where there has to be a capping for the senior most person and the junior most person can rise up to a certain level because everybody can't be giving 100% of the money. So if you start with 10% of, say, the group's money, you may, depending on the numbers, go up to 20, 25%. That would be a cap. That has to be known. At the same time, annual growth has to be given or projected because nobody wants to have an indecisiveness about the financial stability. Yeah. So if you are able to do that and share that revenue in the model that you have decided, I think everybody would probably be happy with that.
Mukesh, anytime you feel equality in the emolument should come or you feel that seniority and juniority, that financial or emolument difference should be there. Can't we have a formula in which work is reduced and money is shared equally or something like that. I mean, I'm just
Yeah,
asking.
so practically equality is difficult because those who would be senior would become more senior, and the junior would naturally be at the moderate level. So what I felt is it should be incentivized. The feeling comes when I am seeing 100 patients and yet I am getting off only 80 patients because my 20 patients money is going into group. So once we incentivize that whoever sees more volume for whatever reason, though it was supposed to be equal, would get little extra money, but a part of it will go to the group. So the group also enriches with it and can probably multiply more centers with it or things like that. So once that is incentivized, that feeling would not come. Like in nursing home also that comes, that it can be a common nursing home, but someone who is seeing more patients, probably if he's incentivized, he'll not be unhappy.
Rajesh, you are in Apex. What is the problem if you don't work but Apex grows and ultimately the shares of Apex grow and eventually instead of individual working hard, somebody else is working and the Apex share goes and at the end you are benefited out of it. So what is the problem there?
So apart from Apex, I just wanted to
Yeah.
tell about this part, that group practice, success of group practice depend upon like-minded people.
Yeah.
And to know whether this person who is joining the group will accept our theme or whatever thinking we have got, then only he should be the full-fledged part of the group. So initial few years, like what a corporate hospital is taking as a senior residency or a junior consultant or like that, in a group practice, if you have got a group of 4 or 5 people who can have 2 or 3 people, nephrologists should join as a full-time, where he can get the salary, and after 3 years, sharing should be given from the common pool. Regarding the senior, who is getting senior and junior are also getting senior after some certain age will decrease their timing and cut down their shares from the group pool.
Yeah, so they should get less money.
Yeah.
But we thought you are saying that the money cannot be cut down, only time can be cut
When
down.
the
That will
time
be unfair then.
Down, the share will come down so that the junior will get a better share because they are working more, they are giving more time, they are feeding more to the group pool, so they will get more money.
Okay, we'll get Dr. Prabir Rai Chaudhary's opinion on whatever he knows. I'm not sure whether he's in group practice, but whatever is the American system and some inputs as to how, we have a few more slides later on, but I think the two people from outside India should be able to give us some clue as to how things happen over there.
Okay, I'll go. Well, first of all, thank you for inviting me to join the panel, and it's a very, very interesting discussion. I have been in academic medicine, but particularly through the American Society of Nephrology over the last 10 years or so, have had a huge interest in overall workforce, and the group practices are a very, very important part of that. So I can give you some of my points. So first of all, I think this was an excellent panel and really excellent moderation, because I think all of the things that I had started writing down in terms of support and schedule and being able to divide people to specialize in different things, I think all of you, that has all been discussed. So I'm going to mention a few things that I think have not yet been, and maybe they are being done, and then give you some general thoughts. So two things that haven't been mentioned to a very great extent is that a lot of the large group practices in the US actually have a portfolio of investments. And they go about it in different ways, and a very close friend of mine is really now the leader of a huge, huge group practice in the US. A lot of this has come from some of the things that that group has done. And the investments, of course, that can vary. Like, it depends on how much people invest in, but often when you start in, if you agree to a certain amount of investment, then that goes towards the group, maybe maybe taken from your initial salary initially. So that's one, and those have been very profitable, mainly in real estate. The second point, which is near and dear to me, is that the large group practices have a tremendous opportunity in something that you've just briefly mentioned, which is clinical research. And in academics, I consider it as a way to get to know about new drugs and get to meet people. In many group practices, that can be a very, very powerful way of actually earning revenue for the group as a whole, particularly if it's done well because of the large volume of patients that such group practices have. One of the things that is very important, and you alluded to it as well, that if somebody goes on the clinical research side or goes into operations and business or goes into public relations, it is important to protect that person's time, because otherwise, the work doesn't get done well, and the person who is interested in it feels that they're just being taken advantage of by the others in the practice. So that sort of protection of time is very important. And then some of the more intangible things, which at the end of the day become the most important, and I think you mentioned it and others mentioned it, the overall mindset of the practice is very important, right? You join people who have a similar mindset. It's very important to get that right. And in academia, it's the same thing. You get somebody with a different mindset, everything goes downhill, right? It's sort of a negative attitude that spreads. Okay. Other things that are very important: transparency, trust, being valued, and being respected. And then for young people, something that's really important, and I would say practices in the US don't do it that well, is to identify opportunities for professional growth for that person. And that could be either in the different clinical areas, so you're targeted to be a transplant person, you're targeted to do onconephrology, but it could also be in other areas like operations and business. Data analytics, for example, is a huge thing that makes your practices more effective, right? Much more effective. In the US, it's very strongly linked to achieving metrics for payment. But right now, for the first time, the metrics for payment actually are aligned, really, for the first time, to at least things that are of value, as opposed to useless things like the hemoglobin or PTH. Right. So I think there's been a huge change which has been in the positive direction. And then the last thing I'd say is that in the right sort of group practice, you actually can innovate. And it's probably easier to innovate within a group practice as compared to a huge academic institution where it's not just your 20 people in nephrology or 30 people in nephrology, it's your 1,500 faculty, right? So if you want to innovate, the guidelines are for 1,500 faculty, not for what you want to do. So I'll stop there.
Before I give the mic to Dr. Bihani, I had invited actually Dr. Nikhil Bhasin to represent the youngsters. Dr. Nikhil Bhasin is how many years post DNB now? 4 years. He's been abroad for 2 years, so maybe 2 years into post DNB program in India. He was offered both the options of joining a corporate hospital and a group practice. He joined corporate. So I thought as a youngster, he would tell us his thoughts as to then and now, whether group practice for youngsters, are they still scared of something, and why are youngsters, of course everybody raised their hands, but when actually it would come, what would they choose? So I wanted the youngsters' perspective of group practice, and therefore Nikhil, I need your comments.
Thanks, sir. So basically I had always worked in an institution. You work in a DM program, you are in a hospital. When I finished my DM training, I was in a government hospital completing my bond. Went abroad, again you are in an institution. So that concept when you come back is like, do you want to run to, in Bombay it is like, covering small hospitals. Are you ready to accept that point, whether you want to cover multiple small hospitals, or would you, want to settle down at one place? But this was my thinking when I came back. But if I have to go back, I think a group practice is a much better option, because like in a corporate hospital upfront, whenever you come back from a fellowship, don't expect to get a consultant position, at least in a city like Mumbai. And as sir was saying, you start off with a senior resident or a junior consultant post, hoping for you to become a consultant. At group practice, the model is different, especially if you know the people in the group, and if they have a same mindset, then it's definitely going to be a more sustainable option in the long run.
So he shifted his gears, which we will again have the poll later on, from what he thought was not a great idea, and now he feels it's not a bad idea. So probably there is some shift in it, and maybe many other people will feel. What are the concerns of a senior partner? I think the senior most right now is Bharat and me. So what are the concerns of a senior partner when you are into a group practice? I agree that yours is a little different model than the kind of model which most of the youngsters would be practicing outside, more into multiple solo people practicing rather than into one corporate. So any thoughts on where is the hitch? What does the senior fear about getting into a group practice?
No, I don't think a senior would be concerned because he builds up his practice with people who are of the same mindset, and they would practice. They would all put in their best efforts to do their practice. So there should not be a concern for a senior partner because he has people who are really putting in their best effort.
Yeah. So I felt that if there are so many seniors being so confident of group practice, most seniors would have taken all the juniors in their corporate hospitals as well as outside to join them in the group practice. But it hasn't happened. So Vijay Kher and then Dr. Biani.
I think the senior would fear basically if one of the persons whom you have taken in takes an advantage. And since I have had a group for last 15 years, although we worked in corporate hospitals, it's been like a department taking multiple people. You try to give them different kinds of work, but it doesn't necessarily translate into that. They want to do everything actually. Nobody wants to do a transplant thing only and a dialysis thing only and a clinical thing.
Correct.
But some people take an advantage. They come late. So these are concerns for a senior person that one person is taking an advantage of this. So as a leader, I think the reason why many people are not, you need to have a very good leader. Unless you have a good leader, otherwise groups will not sustain at all. You mentioned about it.
Yes, I think which is why Bharat is able to do it.
That's right. That's why.
Hopefully I will be continuing to do it. I mean, it's all about.
Youngsters will never feel confident unless there is transparency, trust, and that feeling that there will be fairness to everybody in that sense. They know that the senior might take more money for initial years and all that, but at some point of time, obviously,
equality
the younger one will grow in that fashion, and that's taken for granted. I don't think that's going to grow otherwise.
I think Dr. Biani, sorry, I took,
I'm in Ottawa, which is an academic center. We are a group of 23 people, and we work like it's a fantastic partnership. There are very base, the base rules are quite clear. Each partner comes with a particular amount of shares and then goes, and there is a cap at end of 15 years or so. And then when the new partner is joined, there is an expectation that this partner will do this, like a home dialysis or a transplant or so, depending on who is retiring. And with regards to the concerns of the senior partner, if a senior partner is working full time after a particular age, it is thought to be a problem. He might have not been kind of done well before or something. So we necessarily at a particular age or something, they start cutting down. Either they stop doing calls or they stop taking triage kind of thing. So, and then the other advantage which I think apart from what has been mentioned earlier, is that we are able to take sabbaticals, 6 months sabbatical are regular, so they can do advance their learning and so on.
So Mukesh, you are a great leader, and just want to know what is your view on how to attract and retain talent in a group practice if you are in a group practice? How do you help in attracting and retaining talent?
So basically in the beginning, we are helping them more than they help us. So we keep a good remuneration package for them. They know that even if they start their private practice, they won't probably match with that figure. But we are confident that over a period of time, then naturally they will start doing justice. And within 6 months, probably it will get equalized, or within 1 year it will get equalized. So that's their first incentive. Secondly, we will always screen the mind of the nephrologist who joins, because some of them may be good in clinical practice, some of them may be good in business acumen, some of them would be good in data, some of them in research. So we assign that work to them so that their interest is on.
Yeah. I think the time is running out. There are many other questions, but we would not be able to come up with all the questions to be taken. So what are the pitfalls in the success of a group practice? One is, I think people have, the partners have different definition of success, goals, dreams, etc. and we do not define it in the beginning. Mentoring or team building is defective, as everybody said. There is insecurity of partners both on the side of junior or senior, then it is there. Unfairness, individuality, ego, and more importantly, interpersonal relationships. So, your formula for making group practice successful, each panelist views 1 minute.
So you should have the same mindset and everyone should put in the best effort. That's a sure formula for the group practice to work.
Good interpersonal relationships and good expertise distribution so that everyone gets to do what they like.
Group first. You should not try
Group
to.
first.
That is most important.
Not individual first, group first. Okay.
I already shared.
5 fingers are not same.
Hmm.
Take the positive from the group's partner, and negative is should taken care by the leader.
Okay, if there is no burning question, I'll just summarize that. Identify your horizon, assess your personality. Can you work with colleagues? At least one person raised hand. Sometimes there are different people, different personalities, and you may not be happy working with all kinds of personalities. So, can you work with your colleagues? Come together early in life. Somebody said that the age of group practice should be later. Address each other's concerns prior to joining. Do the paperwork right, Doctor. I think the main reason why US probably succeeds is the paperwork and the legal work is there. You can't just say, dosti yaar mein aaja, we will see later on. That doesn't work. Chalk out roles and responsibility up front. And that's how you will be able to succeed in group practice. There are very few group practices in India, and I hope there are many more. What about the poll again? How many people in the audience will be happy to be in group practice if you were to start afresh? I think. And how many people they are not cut out for it and would not want to experiment it? So I expect that this group, when they come home, they go home, they would try their best to be in group practice. Thank you so much, the panelists and our special invitees, Prabir, for giving us insights into it. Thank you so much.